Hi, my name is Gary Schiller. I'm the chief of the Heme Malignancy Stem Cell Transplant Unit at the David Geffen School of Medicine. And on behalf of my colleagues, we presented at the recent meeting of the American Society of Hematology a poster entitled Once Weekly Selinexor, Carfilzomib and Dexamethasone in Triple-Class Refractory Multiple Myeloma. Despite advances in treatment, multiple myeloma remains incurable, and in almost all instances, the disease becomes refractory to three classes of drugs: immunomodulatory drugs, proteasome inhibitors, and anti-CD38 monoclonal antibodies. The prognosis of patients with triple-class refractory multiple myeloma, what is called in this poster TCR multiple myeloma, is poor because of limited alternate therapies. The oral XPO1 inhibitor Selinexor is approved for treatment of relapsed refractory multiple myeloma, and this approval of once-weekly Selinexor with bortezomib and dexamethasone was based on the Boston phase 3 study in which 195 patients who received Selinexor, bortezomib, and dexamethasone had a median progression-free survival of 13.9 months versus 9.4 months in 207 patients who received only the twice-weekly bortezomib and dexamethasone. The STOMP phase 1/2 study, which was a combination of Selinexor with a variety of other drugs, found that the combination of once-weekly Selinexor with carfilzomib and dexamethasone yielded impressive efficacy. The overall response rate was 78%, and that included 67% response rate in patients with triple-class refractory multiple myeloma. The long progression-free survival in STOMP, extending for more than a year, included those with triple-class refractory disease. And this indicated that the Selinexor-containing regimens provide prolonged disease control with good tolerability. Based on those results, we took a look at Selinexor with carfilzomib and dexamethasone in a subset of all the STOMP patients with triple-class refractory myeloma to explore the tolerability of the regimen in this patient population. The phase 1/2 STOMP trial consisted of 11 arms. They studied different Selinexor-containing regimens. Patients were eligible for Selinexor, carfilzomib, and dexamethasone if they had relapsed refractory myeloma and measurable disease in serum and/or urine per IMWG criteria. Prior therapy with carfilzomib, but not refractoriness to therapy, allowed patients to enter this trial. Patients were administered once weekly Selinexor dose of 60 to 100 milligrams, dexamethasone 40 milligrams once a week, and intravenous carfilzomib at 56 to 70 milligram per meter squared. The table in the center, table 1, shows the demographics of patients included on that treatment arm. Overall, of the 33 patients treated with the triple therapy of Selinexor, carfilzomib, and dexamethasone, 23 had triple-class treated myeloma, and 12 had triple-class refractory myeloma, including 8, or 2/3 of those patients, with high-risk cytogenetics. As shown in the next table, called here Table 2, rates of treatment-emergent adverse effects in patients with triple-class refractory myeloma were comparable to the rates in the full cohort and in the triple-class treated subgroup. Common hematologic treatment-emergent adverse effects included thrombocytopenia, which occurred in 83% of the triple-class refractory group, and anemia that took place or was identified in 58%. Non-hematologic adverse events included nausea occurring in all patients with triple-class refractory disease, decreased appetite and fatigue occurring in 58.3%. However, all events of fatigue and all but a single event of nausea and decreased appetite were considered severity grade 2 or less. These were largely reversible and manageable with supportive care and dose modification. 2 patients discontinued study treatment after 149 and 386 days due to their treatment-emergent adverse effects, specifically cardiac toxicity attributed to carfilzomib. There were no deaths due to treatment-emergent adverse effects. In the next panel entitled Safety and Tolerability, tolerability is evidenced by the duration of study treatment of more than 6 months in 58.3% of patients and a median time to discontinuation of 7 months. The starting dose of selinexor was 100 milligrams in a third of patients with triple-class refractory myeloma, 80 milligrams in 58.3%, and 60 milligrams in 8%. Most of the patients, 83%, had selinexor dose reductions with median time to first dose reduction of 46 days. The median number of dose reductions was 1, and overall, the median weekly selinexor dose was 60 milligrams. In the next panel, where we look at efficacy, entitled Table 3, here you see the outcomes. The overall response rate was 66.7%, including very good partial response in 5 patients, or 41.7%, and a complete response in 1 patient. In the next panel, you can see here some of the other parameters and the conclusion that this combination of selinexor, carfilzomib, and dexamethasone was generally well tolerated, with a good manageable adverse event profile and a median duration of response of 12 months. And these results compare favorably to other studies, such as the Mammoth trial and the prospective LOCO-MM motion study of real-world clinical practice, which found overall response rates of 25% and median progression-free survival of 3.9 months in patients with triple-class refractory myeloma treated with standard treatment regimens. Overall, our results, therefore, show the potential utility of this combination of carfilzomib, dexamethasone with selinexor for patients with triple-class refractory multiple myeloma.